Well, in ALL, it's, our backbones are multi-agent chemotherapy. That's the concept of using non-cross-resistant agents was one of the advances shown in ALL. So it's not as if we're truly using newer drugs there, except, as I mentioned, for example, blinatumomab, post-induction. So that's a trial for age 40 and older. And we'll be opening another trial for younger patients using a backbone that's been shown to be effective in adolescent and young adults. That's improved outcomes, using that chemotherapy backbone and then randomizing post-remission to inotuzumab. So will using these newer agents earlier in treatment change the natural history of the disease? Will more patients survive and not relapse? So I think that's the major focus. As part of that, of course, it's MRD assessment. And can we use that to identify patients very early who are at higher risk of relapse and perhaps intensify their therapy or be more confident about suggesting allogeneic stem cell transplant? It's, the use of allo transplant is still, I think, not entirely clear in adult ALL, who really would benefit from it, who we should offer that to. And then, of course, CAR T-cell therapy as a novel therapy. We do have a drug for T-cell disease, nelarabine, for relapsed T-cell disease. And I think an important issue there is if we add it, again, to upfront therapy for T-cell disease, can we prevent later relapse? So that's a question we'd like to answer. The pediatricians are doing such a study.